Dr. Brie. I welcome you today. Dr. Brie is the Doctor of Audiology at the Center for Hearing and Speech in Manchester, Missouri. Please welcome her today and let's just go ahead and get started. Thank you so much, Dr. Brie.
Hello, thank you. We've got a couple people connecting, it looks like, so maybe we'll give it just a moment. Judith, do you have a way to mute everyone?
Everyone is muted.
Okay, all right, great.
Mhm.
Okay. Let's see, let's give it just another minute or two, see if anyone else joins us.
Okay, sounds good. So also I wanted to mention we have the closed captioning um, on today. So I'm not sure if everyone can see this or um, if it's specific to your own Zoom account. So, but we have it on. So hopefully it's helpful.
Thank you so much for doing that. I
Oh,
appreciate
you're
it.
welcome. You're welcome. I think we probably, Dr. Now should go ahead and get started. If someone
Okay,
shows up, I can go ahead and admit them.
okay,
Okay, great.
sounds good. All right, so I'm gonna share my screen. I'm gonna turn off my video. All right. See if I can hide that. Okay. So thank you for joining me for this presentation today. The title of my presentation is Hearing Loss and Cognition. And as Judith said previously, my name is Brie Noud, and I am a doctor of audiology. I am a clinical audiologist at the Center for Hearing and Speech. I have a bachelor's degree in speech language pathology from the University of Central Missouri in Warrensburg. And then I have a doctor of audiology degree from Washington University. A little bit about the Center for Hearing and Speech. We are a nonprofit. As of last year, 2020, we are 100 years old. So this year we're celebrating 101 years. At the center, we offer several different services: audiology diagnostics, which would be your hearing test, hearing aid services, auditory processing, cochlear implant services. We also have speech pathologists who provide speech therapy. We have school screeners who go into the schools to do vision and hearing screenings. We have a big box truck that drives around and does testing in several different states on the truck, and we are able to screen big corporations and companies. We service the St. Louis metro area, and then we are also unique in that we provide financial assistance. So it's kind of rare to find, and often insurances do not cover hearing aids. So we offer all different kinds of financial assistance, but we do accept private insurance, public insurance. Anyone can apply for assistance. I will have my phone number and my email at the very end of this presentation so that you'll be able to contact us with more information. And give me just a second, because I realized I forgot something. Give me just a moment. Sorry, I printed my presentation without the notes at the bottom, and those are going to be kind of helpful. So give me just a second to get those.
Doctor, are you able to turn your video on so we can see you as you're speaking? That would help me when I lip read.
Does that help?
Yes, thank you.
Okay. Yeah, give me just a second.
Why isn't this on? I'm gonna unmute it.
Okay, I apologize about that. Guess it's Friday. I've had a long week. So now I've got my notes pages. I know what we're talking about. Okay, moving on. So we're going to start with the basics. This is the outer ear that you're seeing on this picture. Hearing is the process of sound traveling through the outer, the middle, and the inner ear. Although sound enters through the ear, it's actually interpreted by the brain. So what you can see here is the outer part, and where it says helix, we also call that the pinna. And then the ear canal is also part of the outer ear. The outer ear leads to the middle ear. So the top left picture, there's a little black box, and that's kind of blown up in the bottom right of the picture. That is the middle ear. It consists of the eardrum and 3 tiny connected bones, which we call ossicles, and those are the malleus, the incus, and the stapes. Okay, the middle ear then leads to the inner ear. This is kind of a snail shape, and it's called the cochlea. That's your hearing organ. It also includes the hearing nerve, which is kind of that yellow part branching off of the cochlea. And then we have these semicircular canals, as you can see on the left side of the picture. Those help you with balance. So how do we actually hear? I'm going to go step by step through the numbers. So number 1, sound is transmitted as sound waves from the environment. The sound waves are gathered by the outer ear, and then they're sent down to the eardrum, or sent down the ear canal to the eardrum. Number 2, the sound waves cause the eardrum to vibrate, which sets those 3 tiny bones into motion. Number 3, the motion of the bones causes the fluid in the inner ear or the cochlea to move. So the inner ear is the cochlea. Number 4, the movement of the inner ear fluid causes the hair cells in the cochlea to bend. The hair cells change the movement into electrical pulses. And then number 5, the electrical pulses are transmitted to the hearing nerve, which we call the auditory nerve, which goes up to the brain, and then they are interpreted as sound. Each part of the ear plays a critical role in transmitting sound. Your natural hearing depends on them working together, and if there's a problem anywhere along the pathway, that's going to probably cause you some hearing loss. As hearing loss occurs, the hair cells that I was talking about in the cochlea, they can potentially die off. And once the hair cells die off, they can't be regrown. So, if you have a really severe to profound hearing loss, you might have some dead hair cells, which we call dead regions. Next, we're going to talk about the types of hearing loss. There are 3 types. The first type is conductive hearing loss. This is caused by something that stops sound from getting through either the outer and or the middle ear. This type of hearing loss can sometimes be treated with medicine or surgery. Kind of depends. Sometimes it's just how your hearing is. The next hearing loss is sensory neural. So this occurs when there's a problem in the way the inner ear or the hearing nerve works. This type of hearing loss is a permanent hearing loss. It's also the most common type of hearing loss. So usually when I see people age probably at least 60 and over, there's usually a little bit of hearing loss, and it's typically sensory neural. Some people actually refer to hearing loss in older age as age-related hearing loss or presbycusis, and almost always it presents itself as a sensory neural loss. And then we have mixed hearing loss, which includes both a conductive and sensory neural hearing loss. So that means there could be a problem in your outer ear and your inner ear, or in your middle ear and your inner ear. Right. So now we're going to talk about the degrees of hearing loss. So when you get a hearing test done and we discuss your results, we don't typically talk in percentages. We talk in severity levels or degrees. So we have normal hearing, then we have mild, moderate, moderately severe, severe, and profound, okay? So this slide just gives you a little bit of info about, generally what you might experience if you have these severities of hearing loss. So if you have a mild hearing loss, you may hear some speech sounds, but soft sounds are going to be hard to hear. If you have a moderate hearing loss, you may hear almost no speech when another person is talking at a normal level. If you have a severe loss, you'll probably hear no speech when a person is talking at a normal level, and maybe some loud sounds. If you have a profound hearing loss, you won't hear any speech and only very, very loud sounds. Hearing loss can also be described in these terms: unilateral, which is one ear, versus bilateral. both ears. When you have a hearing loss, we typically want to see that it's bilateral. We really don't like seeing unilateral losses. That might indicate that there's something else going on. It can also be occur prelingually, which means before a child learns to talk, or postlingually, which is after they learn to talk. Symmetrical or asymmetrical. Once again, we want your ears to be symmetrical. We don't want one ear to have a mild loss and one ear to have a severe loss. That can also indicate maybe some type of lesion. It can be progressive, gradually over time, it gets worse, or it can be sudden, which happens really quickly and unexpectedly. Progressive is definitely more normal. If you have a sudden hearing loss, we usually get you in right away to see the ENT medical doctor, because we don't like to see it happen overnight, essentially. That's usually indicative of something. It can fluctuate. Now, this is kind of rare, and it typically goes along with certain diseases of the ear. So it will likely get worse over time, but it's not going to get better unless you have like Meniere's disease or something that would cause your hearing to fluctuate in that way. It can also stay stable. So we don't really have a way to determine if, your hearing loss is going to get worse as you get older, if it's going to kind of stabilize. So the best thing you can do is get your hearing tested every year or two, just to kind of keep an eye on it. And then hearing loss can also be congenital, which is present at birth, or acquired, which appears sometime later in life. Okay. So during a hearing evaluation, you'll be tested several different ways: through air conduction, bone conduction, and then we will also complete some speech testing and word discrimination testing. So for air conduction, you will listen to tones or beeps of different frequencies under headphones. And then what we want to do is find the very lowest possible volume of detection at each frequency or pitch. So air conduction tests the entire hearing mechanism, the outer, middle, and inner ear. We're also going to test bone conduction. So we use a bone oscillator, and we actually place it behind one ear on your mastoid bone back here. And then this, the oscillator will transfer sound directly to your inner ear. So that's only going to test your inner ear. It's going to bypass the outer and the middle ear. And then word discrimination. This tests your ability to understand speech at a comfortable level. You repeat back a series of words. This is the only part of the evaluation where we actually give a percentage, because we're giving you a percentage correct. You correctly repeated back 96% of the words. So that's the only time we're going to use the percentage. Using air and bone conduction helps us determine what type of hearing loss you have. If it's that permanent sensory neural, if it's conductive, or if it's got a mix of both. So a little bit more about word discrimination. This test just gives us a little bit of extra clinical information. So it's not necessarily done to see, okay, if we give a person hearing aids, are they going to do well? Because you're in a quiet booth, you've got the sound going to only one ear at a time. You're not getting any visual cues because you're not looking at the person. So really the purpose is, there's 4 different purposes. Does the patient's performance subjectively agree with his or her pure tone hearing loss? So if you have a very mild loss, but you're only able to correctly discriminate, 20% of the words, we might have something else going on there. It also can identify unusual asymmetry that we don't see with air or bone conduction audiometry. So even if your air and bone conduction tone testing, if your ears look like they're right on top of each other and they're symmetrical, but then your right ear correctly gets 100% correct and your left ear gets 50% correct. Okay, we don't like to see that either, because that doesn't really match up with what we expect. We can also use it to monitor your performance over time and see if your discrimination gets poorer as you age. Sometimes that correlates with your pure tone thresholds changing, and sometimes it doesn't. Sometimes it's just part of aging and all of your processes, including your cognitive processes, slowing down. It's not really a good way to tell. It can also assist us in making amplification decisions. So if you have a relatively symmetrical hearing loss with the pure tones, but maybe an asymmetric word performance, that could influence which ear we might fit if you can only purchase one hearing aid or you only want to purchase one hearing aid. So understanding the audiogram. So what you're seeing here is an audiogram. It is a graph that we make that is based on how you respond to the beeps that we're presenting. So across the top where it says 125 all the way over to 8,000, that's frequency or pitch. On the side where it goes -10 all the way down to 130, that is essentially volume, which we measure in decibels. So the higher the number means the louder the volume. The audiogram is a graph that shows the softest sounds that a person can hear at each frequency. So the closer that your cymbals are to the top of the graph, that means you have better hearing. If they fall at the 20 decibel mark or above, that would be the normal hearing range. So where the cymbals fall on the audiogram, that indicates your degree of hearing loss. So the circles on the graph represent the right ear. The X's represent your left ear. Okay. So this is a little bit more about the degrees and severities of hearing loss, but now you can actually see it on the graph. So the top part where it says normal, that's normal for pediatrics or for kids. Where it says normal to slight, that's actually the normative range for adults. So anything normal and slight, that would be normal for us. And then below you have mild, moderate, moderately severe, severe, and then profound at the bottom in that lilac color. So a few facts about hearing loss. It's present in 20.3% of Americans aged 12 years and older. Generally, the prevalence of hearing loss increases with age. And then hearing loss is actually present in 360 million people worldwide, which equates to about 5.3% of the world's population. Now, someone did ask me once, why is that number so much lower? Probably because in a lot of areas, people are not getting tested or getting treated for hearing loss, which is why that number is quite a bit lower. And I put this picture on here because I think that probably this picture looks pretty familiar to some of you. So what is our biggest concern with the effects of hearing loss? Number one, speech intelligibility. And number two, increased cognitive burden. So we're going to talk about that. That's the big part of this presentation. Studies show that listeners with poor hearing also have poorer memory for what they've heard. So it's harder to remember things if you're not fully hearing and understanding the conversation. Okay, so as audiologists, we're aiming to improve your ability to understand spoken language. But understanding spoken language requires more than just your ability to hear. So to understand this, we can consider how the intended speech signal can become degraded within both the environment and in the listener. In natural conditions, speech often occurs with reduced sensory detail due to signal degradation caused by background noise or competing talkers. So that's usually people's biggest complaint. They come in and they're like, I just can't hear, but especially in background noise. That is the most difficult situation. So background noise actually causes the ears of those with hearing impairments to work differently. When you're in noise, the neurons in your inner ear, they have to work harder because there's some of those dead regions that they were talking about, and the neurons are then spread too thin, okay? When you have normal hearing, you've got these channels and the neurons directly correlate with the channels, very finely tuned. When some of those neurons die off, they're trying to cover larger channels, so they're working harder. Okay, this is comparable to turning on a dozen TV screens and asking someone to focus on one program. They may remember parts of the program, but they're probably not going to remember all of it because they're getting distracted by the other information. So there's essentially no change, even for those with hearing loss, in terms of how the neurons work when we're in quiet surroundings, okay? But when noise is added, that's when we have a problem. That's when the problem begins. So I kind of already said this part, but the auditory system in the inner ear filters sound into a number of channels that are tuned to different frequencies. Like I said, in a normal system, they're very sharp and focused, but they get broader and more scattered with hearing impairment. Okay, so next we're going to discuss unclear stimuli. So in previous studies of spoken language, researchers have experimented with acoustic clarity of speech and discovered that brain activity levels vary based on how unclear the stimuli are. So when listeners hear speech, you have to match the rapid incoming stream to stored representations of words and phonemes that are in your brain to determine the intended meaning. The process of correctly identifying sounds is made more difficult when speech is acoustically degraded. So less information is available to the listener, which reduces the quality of speech cues and then increases the chances for error. Another factor is lexical effect. So what that means is how common a word is in the English language, or how many words sound similar to a target word can impact word recognition. So in the context of lexical competition, words with a large number of competing targets, like cat, can be confused for cap, cab, etc., or words that are less dense, so words that are rarely used in speech, are more difficult to accurately perceive. Additionally, context can affect a hearing impaired person's ability to understand speech. If you're chatting with your friends and you're talking about the baseball game, you're likely going to be able to fill in all the blanks with context because you know what the conversation is about. So even if you miss a few words, you're probably still able to figure out what's being discussed. But if you're talking about baseball and then all of a sudden someone chimes in with what they had for dinner last night, you're probably going to have a more difficult time filling in the blanks because now the context is gone and you've completely switched the conversation. So now we're going to discuss signal degradation in the listener. So this is in you. So hearing loss and the configuration of your hearing loss reduce accuracy of the perception of spoken words, even when the words are spoken with adequate volume and clarity. So another complaint I get a lot of times is that everyone's mumbling. I'm sorry to inform you that not everyone is mumbling. Maybe some people are, but the reason it sounds like people are mumbling is just a product of the hearing loss. So even when they may be talking very clear and enunciating well, to you it may sound more garbled. Older people with a moderate to severe hearing impairment have a 29 to 57% greater risk of cognitive impairment than those with normal hearing. In a recent study compared to those with normal hearing, individuals with hearing loss had a 24% increased risk of incident cognitive impairment. Rates of cognitive decline and the risk of incident cognitive impairment were linearly associated with the severity of an individual's baseline hearing loss. Okay, so the configuration of your hearing loss has a lot to do with it as well. So a lot of times people say to me, you know, I can hear that people are talking, I just don't understand what they're saying. And that is directly related to the configuration or the shape of the hearing loss. A lot of people with permanent hearing loss, especially age-related, have better low frequency hearing than they do high frequency hearing. And that's what you see in this on this graph. 250, 500, 1,000, those are all up in the normal range. And then you can see it kind of slopes down and we get down into the severe range in the high frequencies. So male voices and vowels are what fall in the low frequencies, and vowels are what give us the volume in speech. Children's and women's voices and consonants fall in the higher frequencies, and that's what gives us clarity, okay? So that's why you get that effect of, I can hear that people are talking because you're getting the volume, but you don't always understand what they're saying because you're missing the clarity with missing those consonants. And lastly, we're going to talk about age. So the brain must compensate for the lack of auditory input, and these cognitive processes are particularly difficult for older listeners. The normal aging process is associated with declines in certain cognitive abilities, such as processing speed, memory, language, visuospatial, and executive function abilities. As a person ages, his or her brain faces significant changes. One study actually found that as older adults listen to spoken sentences, their brains use many of the same regions as younger adults, so that's good. But it also showed that they used additional regions of their brain that is not used by younger adults. So that's a sign of increased listening effort or cognitive burden that you would need to fully comprehend spoken language. There is significant variability in age-related cognitive changes from individual to individual. Some of that variability can be attributed to genetic differences, and studies estimate that 60% is probably attributed to genetics. Medical illness, psychological factors, and other sensory deficits such as vision can also accelerate age-related cognitive decline. Participating in certain activities, building your cognitive reserve, cognitive retraining, socializing in general, these can all be approaches to achieving successful cognitive aging. So what does a combination of background noise, unclear stimuli, lexical effects, severity configuration of your hearing loss, and age lead to? Well, all of these factors of signal degradation can cause you frustration, mental exhaustion, which may eventually even cause a person to become isolated and avoid social settings. We refer to all of this as listening effort or listening fatigue. To maintain optimal understanding, listeners with hearing loss must allocate more cognitive resources or brain power to listening than do listeners without hearing losses. But the problem is our resources are not unlimited. So using additional cognitive resources to listen leaves fewer resources available for other tasks. So for example, to maintain optimal understanding in a challenging situation, a person with hearing loss may need to shift more resources from other ongoing tasks like visual processing or memory rehearsal than individuals with normal hearing, which will probably impact the ease of communication. When hearing loss is present, the brain has to compensate for the loss and work harder than before to process the same information, which causes stress on the brain and then fatigue. So what can we do about it? The short story is that it's pretty complicated. There's a lot of research about it, but there's not much that can be done. So there's no definitive proof that hearing loss causes dementia or cognitive decline, or even that it speeds up the rate of either. There are, however, many studies that show some sort of link between untreated hearing loss and cognitive decline. Thus, that's why I put this in. Correlation does not equal causation. All right, this is a little bit of research now. A long-term study of 2,040 older adults found that cognitive decline was significantly reduced in subjects who used hearing aids. The subjects were age 50 and older. They had no dementia at baseline, and they began using hearing aids during the 18-year period. Cognitive function was assessed using short-term and delayed recall of a list of 10 words. So we call that episodic memory. Before using the hearing aids, participants could remember 0.1 fewer words on the memory test per year on average. Following hearing aid use, the average rate of decline was reduced to 0.02 fewer words recalled per year. That doesn't seem like a big difference, but in statistical world, anything 0.05 and lower is considered a statistically significant difference. So that's actually a pretty big difference. This suggests that effective identification and treatment of age-related hearing impairment may have a significant impact on age-associated cognitive trajectories and possibly reduce the incidence of dementia. Dementia is a major global health problem. A study completed in 2018 suggested that treating risk factors could prevent or minimize 35% of dementia cases. It also found that the strongest of the treatable factors is untreated hearing loss. On average, respondents in this study began using hearing aids at age 62. After controlling for other covariates like age, gender, physical activity, and smoking, results indicated that episodic memory declined with age, but the rate of decline slowed significantly after beginning the use of hearing aids. So some other effects of untreated hearing loss may be depression, anxiety, frustration, social isolation, and fatigue. One study completed in 2018 attributed these negative effects of untreated hearing loss on cognition to two possible causes. Number one, both hearing loss and dementia are caused by age-related decline in the central nervous system. Or number two, the decline is due to auditory deprivation and the resulting reduced social engagement and increased depression and anxiety. They argue that their findings support the latter explanation and suggest increased access to quality hearing healthcare might delay the onset of cognitive impairment and help reduce the impending dementia epidemic. This study was done in 2015. It examined the relationship between hearing loss, hearing aid use, and cognitive decline. This epidemiological study followed 3,670 randomly selected older adults over a 25-year period. Of these, 1,276 self-reported hearing loss, while 2,394 reported no hearing loss. The population was divided into three groups. Number one, no hearing loss. Group two, hearing loss and no hearing aids. And three, hearing loss with the use of hearing aids. Subjects were seen about every 2 years over the 25-year period with neuropsychological evaluations of cognitive performance, cognitive complaints, and functional ability given at most visits. At baseline, all of those reporting hearing loss had significantly lower scores on scales of global cognitive performance compared to the group reporting normal hearing. At the 25-year follow-up, the subjects that were not using hearing aids declined more rapidly on cognitive performance measurements than those who used hearing aids. Furthermore, Subjects with hearing loss who used hearing aids had no significant difference in cognitive decline from the control group. And the control group is those with self-reported no hearing loss. Although this long-term study found that adults who used hearing aids did not experience the cognitive decline associated with untreated hearing loss, this was not a randomized controlled trial. It may be that adults who choose to use hearing aids differ in other ways from those who choose not to. Okay, and that is all I have for you. Let me get my mouse back, and I am going to leave this screen up for a moment so you can see the phone number and my email. And then if anyone has any questions, you can feel free to ask now. I don't know if there was a chat box or anything. Oh, there
There
was.
is a chat box, and I will help with the chat box. And if I see some questions, I will give you a heads up or
Okay.
so if you do have questions, everyone, you could type in the chat box or raise your hand. I don't see any at the moment. Harvey?
I have a question.
Yep.
I wear hearing aids, and when I'm watching normal television, I can hear fairly well. But when I go to like Netflix, it I don't hear it quite as well, and I don't know if that's because there's a little delay in the transmission or what causes that, and what can I do to improve the hearing?
That just may be due to the specific programs and the difference in watching Netflix versus your TV. I turn my subtitles or closed captions on for my Netflix account. I have no hearing loss at all, but I still like to be able to read the words so that, you know, if I am unable to understand, I can tell what was said.
Thank you.
So that may just be due to Netflix.
Linda Kramer has a question. What options are available in hearing aids?
So I'm not sure if you mean what styles or what kind of features are available, but they're actually, let me just get a little demo box and I'll just kind of show you a couple. So there are 3 general styles of hearing aids.
Diane, Dr. Brie, can we
Yes.
take down the PowerPoint, then we can see you better while you're
Okay.
showing? There you go. Great.
Can you
Thank
see me
you so
better?
much.
Okay.
Yes.
So we have 3 general styles of hearing aids. The style depends on number 1, your hearing loss, number 2, your dexterity, and number 3, you know, your preference of what you like. So we've got, this is kind of a standard behind the ear. Okay, it's got like a custom ear mold piece. This piece that's behind the ear. We've got this here, which we call a receiver in the canal. I will say that probably 90% of my patients have something like this because it's nice and small and sleek. It can either have this little rubber piece on it, or it can even have something like this on it instead, where it kind of just has a little custom ear mold piece. And then there's also just a general custom style that you would just insert in the ear. So those are the styles. If you're referring to options like features, different companies have different features. Every company also has 4 technology levels, and that's really where the price comes in. And so if you come in and do a test, or if you've had a test done and you just want to do a consultation, that's something we would just discuss to define or to find out what's most important to you, what your lifestyle is like, and then that's kind of how we decide where we would go with that. I believe that at this point, all hearing aids are now Bluetooth compatible. Some of them are more privy to iPhones, but there are a couple brands that will directly connect with Android if that's the type of phone you have. So hopefully that answered your question, Linda.
Jerry, do you have a question? Jerry, Jerry need to unmute.
There, oh, hold on, you were there.
Jerry, I think you still need to unmute.
Can you
Okay.
hear me now?
There we
Yes.
go.
All right. I'm 84 years old. I've had hearing aids for a number of years, and I got mine in Costco, and they checked me. And I checked with them periodically to see if there was anything better on the market, and they tell me no. It's apparently there's not too much difference in the quality of the available hearing aids. I wanted your comments.
Okay. A few thoughts. Number one, every hearing aid manufacturer comes out with a new hearing aid technology every year, if not every 2 years. Now, some releases may be negligible difference between the previous release, but sometimes there's something big that they're like, we added this really awesome technology. It's a lot different than what we've had before. So I guess it would depend. I know that Costco typically has contracts with specific manufacturers, so they don't always fit what like I would fit. I can't program like what hearing aids you got from Costco. So they, I think, partner with a manufacturer based on whoever's got a good contract that year. So as far as I've been told, I think it changes of who they work with. So that might depend too if who they're working with at the time, what the technology is. Do you know what brand of hearing aid you have?
I can't remember that right now.
Okay. Like I think most recently they were working with Phonak.
Phonak?
It's not Phonak.
Signia, Rexton. Trying to think who else they worked with recently. Okay, I'm not sure then. So it's possible that maybe from what you have, there's not newer technology, or maybe not anything new enough to really allow you to say, okay, the cost benefit is acceptable. Does that make sense?
It does, because what you had on your program fits me perfectly. I have all those problems.
Yeah, that's pretty standard. And at the center, we fit all 7 manufacturers. So we're not tied to 1 or 2. We're not contracted to anyone. We pick the manufacturer based on your needs. So that's kind of the benefit of coming to us as well.
What I need is about 20 years of age.
I don't think I can provide that, unfortunately. Sorry.
Leonard has a question next.
Yes. 2 years ago, I had 100% sudden hearing loss in my right ear, and I lost my balance at the same time. I do wear hearing aids now, and I can hear sounds pretty good. I have about a 60% hearing in my left ear, but I cannot discriminate words very well, and the female voice or the higher ranges are very impossible for me. I wonder if there's anything further I can be doing that might give me the ability to understand rapid speech by news commentators, especially women.
First question, with that sudden hearing loss, Did they give you any steroids or did they do any medication for that?
No, the eye, ear, and nose throat people said that they thought I had a probably blood to the inner ear flow was
Okay.
cut off by some reason.
Hmm.
And they said that the inner ear is the one that's causing me the bad balance. And so I did all kinds of therapy for balance. I'm on a walker because that's as good as I could get. But the hearing has not returned at all.
Okay. So it's still very, very poor in your right ear, but you still have some discrimination in your left ear?
Yes, yes.
Okay. So the best thing I can say is if you're going to have a conversation with someone, you need to be, not necessarily one-on-one, but facing them so you can read their lips. Even if you don't realize that you're reading lips, a lot of times, even people with a mild hearing loss are reading lips because it's just natural to want to fill in the blanks of what you're missing with the auditory, with the visual cues. So if you can see their face and see their mouth, that's the best thing. Now on stuff like the TV, that's definitely difficult because it depends on the program. It depends on the speaker. It depends on your TV in general. There are certain accessories that you can get that will connect to your TV, and you can wear like little TV ears that might help you. There's a website that's called Teltex. I'm going to type that into the chat actually. But you can look online at their catalog. It's teltex.com. And they have a lot of different accessories, including like TV ears or TV connectors. So if that's something that really bothers you and you watch a lot of TV, that might be something to look into. Did you say you do wear hearing aids?
Yes.
Okay. It's possible that the hearing aids you have might also have, that company might have a specific TV device. So you might check with your audiologist to see if there's something that will work with that as well.
Yeah, the hearing aid I have is a Phonex, and there's a little microphone that they gave me, which I could
Okay.
give to the other person, which
Okay.
would help. They also, the doctor said that I ought to think about cochlear implant, but I'm 94 and a half years old, and I sort of thought that's too late for that.
No, we've had plenty of 90-year-olds that have gotten cochlear implant surgeries and done really well. So I wouldn't have your age be the issue. When we go through the whole process of determining if you're a candidate, you will see the ENT, you do scans and make sure everything, in your inner ear is in place the way it should be. But it would depend more on your health than anything, but your age doesn't really have anything to do with it. So if that's something you want to consider, you might consider it, because that could really, change your last few years of life. Like if you get an implant and it works really well for you, doesn't matter how old you are.
Okay, so you think there's a percentage chance that the implant might do something for the right ear, which is the ear they were talking about, which has no hearing?
Well, because an implant, it works totally different than a hearing aid. So when you put a hearing aid on, it's got to go through the outer, the middle, the inner ear. And what it sounds like is you have a lot of dead regions because maybe a lot of your hair cells have died off. So what the implant does is it's got literally a little tiny electrode array that's like a few millimeters long. Well, it's a few millimeters wide, a few centimeters long. And it coils into that little snail-shaped part of your inner ear, and it sends electrical pulses to the brain. So when you don't have those hair cells there, those electrodes take the place of that and give you that sound. So totally different than a hearing aid. But that would be something to talk about with the cochlear implant audiologist.
Thank you.
that answer your questions?
Yes, and I can understand you as you speak very clearly. So that's a good thing.
I get that a lot. I think I've just kind of learned how to speak well.
Myron would like to ask, how often should you check to see if you need a different hearing aid from the one you now have?
So number one, Myron, I would get a hearing test, like I said, every year or two. And then that will give us a chance to kind of look at your hearing aids, clean them up, make sure they're in good working order. I would say at this point, with the hearing aids being as advanced as they are, people will go 5 to 7 years before they replace them. That's not to say it can't go longer, but usually by that point, people are kind of ready to shift to something new. So it would really just depend on, number one, your hearing loss. If you go from having really mild hearing loss to a profound hearing loss, that's very dramatic. But, you know, if something like that happened, we would maybe say, okay, we might need to explore a totally different type of hearing aid to give you more power. Or if your hearing aid's starting to get old and it needs a repair, we might say, hey, it might be worth it just to completely get new hearing aids instead of repairing this old hearing aid, because you may have to repair it several times. Does that answer your question, Myron?
Yes, thank you.
Okay.
Do we have some more questions? Yes. Arthur, we need to unmute.
Okay, can you hear me now?
Yes.
There you
Okay.
go.
What kind of hearing aids do you have where you work? What are the brand names?
She said,
Sorry, you kind of cut out. Will you repeat your question?
The brand names and the prices of your hearing aids, the average. I know you can't give specific ones because you don't know particularly my problems. But I have Costco hearing aids now. And I have Phonex. And they're good, but as you say in Costco, they don't upgrade. As Jerry said, they don't come out with new models. So I'm wondering if I would get at your facility, a hearing aid, would it be better than what they had at Costco?
Okay, I'm going to let you in on a few secrets about Costco, places like Beltone, Southwestern, Miracle Ear. Number one, they're very driven, okay? They want to sell you hearing aids and they want you to upgrade, you know, every few years. So that's number one, the difference between us. We're not sales. I don't get commission. There's no quota. I'm just trying to help you hear your best.
Yeah.
Number two, typically the people who are testing you and fitting you at those places are hearing instrument specialists. So they, you know, have a high school diploma at least, and then they just have a short certification, and then they're able to do the same things that I'm able to do. I went to school for 8
It's
years.
11 o'clock.
Uh-oh.
I think, go ahead.
Okay. Let's see, what was I going to say? Oh, number three, I don't know about the other places, but Costco specifically, since they contract with different brands every few years, the hearing aids that you're getting are brand new, but that technology is 2 technology chips behind. So something that's brand new at Costco for you is like me fitting an older hearing aid on you, if that makes sense. So if you go get a 2021 Honda, that might be what you get from me, but you go to Costco and they say, I have this brand new car, but it's a 2019, and they don't tell you that. They may not even know that, I'm not sure, but I do know because I've spoken to the representatives with the companies before to ask them what the difference is in technology. And that's a big part of it, is that it's old technology.
And what do your prices range from on the hearing aids?
Okay, the hearing aids for us range from 2,800 for a pair up to 5,300 for the pair. Like I said, we have 4 levels of technology. When you come in, we talk about your lifestyle, what you're looking for, if you have a budget, and we go over all of that. If you come in and you're like, I want the best of the best, I give you the best of the best, but I'm never going to push that on you.
Okay, thank you.
Well,
Yep.
thank you so much, Dr. Noud. I don't believe we have any further questions at the moment, and we're a little bit over time. Anyone else have a question that we would like to address today
Okay.
before we
When we go to the
finish?
theater- when we go to the theater, you can't understand that.
I don't think so. So thank you so very much. We appreciate everything that you have given us today. Bye, everyone.
Thank you.
Oh, no,
It's too late.